So you're out for a run, you're laughing at a great joke, or maybe you just have, a sudden violent sneeze and there it is, a small leak.
Yeah, stress urinary incontinence. It's incredibly common.
Right. And it's a reality that totally changes how you exercise, how you socialize, even how you dress. I'm your host, and today we're tackling a topic that affects so many of you.
And I'm your resident medical expert. Glad to be here for this one. It's an issue that isn't talked about nearly enough.
Exactly. Because for a lot of people, making the leap from just doing daily pelvic floor exercises straight to undergoing traditional surgery, that feels like a massive, daunting escalation.
Oh, absolutely. Surgery is a huge step, but today's deep dive is really about that middle ground.
Yeah, and we have a fantastic mission for this deep dive. We've gathered this huge stack of FDA approval documents, clinical trials, and medical literature to answer one highly specific question.
It's a fascinating question, really.
It is. We want to know how injectable bulking agents, specifically this product called Bulkamid, actually restore a mechanical process in the body known as urethral coaptation.
Right, which sounds incredibly technical, but it's basically a highly precise internal plumbing fix.
Okay, let's unpack this. If you think about fixing stress urinary incontinence, or SUI, with this method, it's basically like trying to fix a leaky faucet from the inside out.
That's actually a great way to look at it.
Right. You're fixing it without actually replacing any of the pipes. You're operating entirely within the existing hardware.
I completely agree with that analogy. You are going inside the anatomical structure to change how that structure behaves under pressure without making a single surgical cut.
Which is wild when you think about it.
It is. Achieving that requires some highly precise science, which is why today we're going to look at the exact physics, the biological theories, and the procedural engineering that makes this possible.
Because fixing a leak from the inside sounds appealing, obviously, but the immediate hurdle is finding a material that actually works.
Right, because the material dictates the entire mechanism.
Exactly. If you inject a liquid, it just washes away. If you inject something hard, well, it creates an obstruction.
Which you definitely don't want. But before we get into the gel itself, we should probably establish the baseline mechanics of SUI.
Yeah, let's do that. Because the structural problem isn't just about a weak bladder, is it?
No, not at all. The problem is really a pressure mismatch. So the urethra has a sphincter, which is just a muscular valve at the bladder neck designed to hold urine inside.
And under normal circumstances, that valve stays tightly closed.
Exactly. But when you do something that forcefully increases your abdominal pressure, like coughing or laughing or lifting a heavy box, that pressure spikes downward.
So the force pushes down on the whole system.
Right. And if the sphincter and the surrounding pelvic floor muscles are strong, they absorb that downward force. But factors like childbirth, menopause, or just natural collagen loss can weaken those support structures.
And when that happens, the sphincter just can't withstand that sudden spike in pressure.
Precisely. The physical force overpowers the valve, and urine escapes.
Basically, the door gets blown open by the wind.
That's exactly what happens.
So to fix this without major surgery, the medical field developed these urethral bulking agents. And the one we are focusing on today, Bulkamid, is heavily detailed in our sources.
Yes, the literature describes it as a non-particulate homogeneous urethral bulking agent.
Right, and the detail that immediately stood out to me in the FDA documents was its composition. It consists of 97.5% water and only 2.5% cross-linked polyacrylamide.
It is overwhelmingly just water.
Which is crazy, because that raises an obvious physiological question for me. If it is nearly 98% water, why doesn't the body just absorb it?
It's a fair question.
I mean, if I inject normal saline into tissue, it just dissipates into the surrounding cells. How can water possibly fix a structural leak?
Well, the answer is entirely engineered into that remaining 2.5%. That polyacrylamide forms this cross-linked matrix. You can visualize it as this microscopic, three-dimensional sponge made of incredibly strong synthetic bonds.
Ah, I see. So the water is trapped in the sponge.
Exactly. The water molecules are trapped within this complex matrix. They can't leak out. And the body's enzymes actually can't break down those synthetic polyacrylamide bonds to get to them.
Wow, so it forms a stable, permanent hydrogel.
It does.
It functions like a microscopic water balloon that never pops, basically holding its physical volume indefinitely.
That's a perfect visualization. And to really understand why a stable, non-degrading water gel is such a huge breakthrough, we have to look at the rather dark history of earlier injection.
Oh, yeah. The historical research was pretty intense.
It was.
Yeah.
Older bulking agents were what we call particulate agents. Doctors were injecting tiny solid microparticles made of carbon-coated beads, calcium hydroxylapatites, or even solid silicone.
Yeah, and looking at the sources, the body does not react well to foreign solid particles being permanently deposited into delicate mucosal tissue.
Not at all.
Yeah.
In fact, the entire mechanism of action for those older agents actually relied on a hostile immune response.
Wait, really? They wanted the body to attack it?
Yes, the body would detect these foreign solid particles and mount an inflammatory reaction, sending white blood cells and macrophages to attack them.
This sounds terrible.
Well, when the body realized it couldn't destroy the particles, it would wall them off by building thick scar tissue around them.
Oh, I see.
And this combination of the injected particles and the resulting mass of scar tissue, which is called a granuloma, that is what actually created the physical bulk used to close the urethra.
Relying on a controlled, localized allergic reaction to fix a structural plumbing issue sounds highly unpredictable.
It was incredibly unpredictable.
Because you're depending on the patient's immune system to build, like, the exact right amount of scar tissue.
Exactly, which varies from person to person. The severe risks associated with those particulate agents are really well documented, and we'll get into those specific complications later.
Right. But Bulkamid, being non-particulate and homogeneous, takes an entirely different approach, right?
It does. It achieves its bulking effect purely by the physical volume of the gel being injected. Because it's almost entirely water, it's highly biocompatible.
So the body doesn't freak out.
Right. It's not biodegradable and non-absorbable, but crucially, it doesn't induce that aggressive inflammatory reaction. It just integrates into the tissue and peacefully occupies space.
So it basically acts as a passive space-occupying implant.
Precisely.
Now that we understand the material is this stable hydrogel that the immune system essentially ignores, the next step is exploring how this specific material physically stops the leaks.
Right. Getting into the actual mechanics.
Because the core focus of the literature, and really the entire goal of this procedure, is restoring a state called urethral coaptation.
Yes. The whole goal here is getting those inner walls of the urethra to rest flush against each other again so the tube stays sealed. That is coaptation.
Okay, so the walls are touching.
Right. In a healthy resting urethra, the mucosal lining folds in on itself, completely closing the lumen, or the opening.
But in a patient with a SUI, that's not happening.
Exactly. Those walls might be gaping slightly open at rest, or they simply lack the mucosal elasticity to stay pressed together when the abdominal pressure spikes.
Got it. So the injection targets the submucosal tissue, which is the layer just beneath the inner lining of the urethra.
Yes, exactly right, under the surface.
And by depositing the gel there, you are artificially thickening the walls. You're basically pushing the opposite sides of the tube toward the center so they meet in the middle again.
That's the physical goal, yes. And the literature outlines a couple of biomechanical theories regarding how this artificially restored coaptation actually prevents leakage during those stress events.
Okay, so how does it hold up when you sneeze?
Well, the primary mechanical theory is that the gel increases urethral resistance and enhances the inherent seal effect. By depositing the hydrogel in a very specific location near the bladder neck, it creates what the medical texts call cephalid elongation of the urethra.
Let's break down that mechanism a bit. Cephalid meaning toward the head, right?
Yes, exactly. Upward.
So by propping the urethra up slightly with this gel, you are physically shifting that segment of the anatomy upward back into the abdominal cavity's main pressure zone.
Exactly. And this slight anatomical shift changes the physics of a cough or a sneeze.
Oh, so?
When the abdominal pressure spikes, that force pushes down on the bladder, trying to force urine out. But because of this cephalid elongation, that exact same abdominal pressure is now also pressing from the outside against the top quarter of the urethra.
Oh, wow. So the problem is actually being used as the solution.
That's a great way to phrase it.
The downward force of the cough squeezes the top of the newly supported urethra shut at the exact millisecond the bladder is being squeezed. It basically pinches itself off.
Yes. It maintains the seal during a Valsalva maneuver, harnessing the patient's own abdominal pressure to reinforce the closure.
That's brilliant.
It is. But beyond this purely physical mechanism, there is an alternative biological theory discussed in the urological studies too.
What's the biological theory?
It suggests that the precise placement of the gel might create a zone of increased contractility in the rhabdosphincter.
Which is the striated muscle surrounding the urethra.
Exactly.
So the gel is literally physically stretching the muscle fibers from the inside out.
Right. And in muscle physiology, slightly stretching a muscle spindle can prime it, making its subsequent contractions faster and stronger.
So the injection might not just be a passive block. It might actually be mechanically helping the surrounding muscle work more efficiently.
Right, it creates a highly responsive environment.
Here's where it gets really interesting. This makes me think of adding a highly specialized weather strip to a door.
Oh, I like where this is going.
It creates a completely tight seal when the wind blows hard against it from the outside, which, represents the sudden abdominal pressure from a cough. The harder the wind blows, the tighter the seal becomes. But it doesn't lock the door. The weather strip still yields easily when you actively turn the knob to push the door open from the inside when you actually want to leave.
If we connect this to the bigger picture, that dynamic response sealing, tightly under sudden pressure, but yielding smoothly for normal voiding, is really the holy grail of incontinence treatment.
Because you don't want a permanent barricade.
Exactly. Surgical procedures that rely on static obstruction, like slings, can sometimes overcorrect the anatomy.
Right, they create a functional obstruction.
And if a sling is too tight, the patient might have trouble emptying their bladder completely. Over time, because the bladder muscle has to work much harder to push the urine past that surgical barricade, it can lead to overactive bladder symptoms.
Or even damage to the upper urinary tract, according to the sources.
Yes. So a dynamic hydrogel avoids forcing the bladder into this compensatory overdrive.
But obviously, this delicate dynamic seal relies entirely on perfect internal geometry. I mean, if the weather strip is applied unevenly, the door won't close.
That's exactly the challenge.
So how does a doctor actually get this gel into the exact right spot inside a tiny tube without making any surgical incisions?
Well, the engineering of the procedure itself is heavily detailed in the clinical instructions, and it is entirely dependent on spatial precision.
Because they do this right in the office, right?
Yeah, it's performed on an outpatient basis. It typically takes only 10 to 20 minutes, and it's done under just local anesthesia.
Okay, so the physician uses a cystoscope or a urethroskop, which is basically inserting a small instrument with a viewing camera directly into the urethra.
Right, which gives them a real-time illuminated view of the mucosal lining.
And then they place 3 to 4 deposits of the Bulkamid gel into the submucosal tissue. But the volumes we're talking about are incredibly small, right?
Very small. The sources note 0.2 to 1 milliliter per deposit.
Wow.
The total volume injected across the entire procedure is usually between 1.5 and 2 milliliters.
That's like less than half a teaspoon of material total.
Exactly. So location and symmetry are absolutely everything. These deposits are placed into the proximal third of the urethra, approximately 1 centimeter away from the bladder neck.
And to achieve that perfect coaptation we discussed, making the walls touch gently in the dead center of the tube, the depots must be arranged perfectly circularly on the exact same horizontal plane.
Right. The clinical literature specifically mentions injecting at the 3, 6, and 9 o'clock positions, or sometimes in a 4-point pattern at 10, 2, 5, and 7 o'clock.
Because if these deposits aren't perfectly aligned on the same axis, the walls won't meet correctly, right?
Exactly. They would just create asymmetrical lumps inside the tube rather than a uniform, perfect seal.
But maintaining that perfect geometric plane inside a human urethra has got to be mechanically difficult for a doctor.
It is. Historically, if a doctor needed to inject at 3 o'clock and then move to 9 o'clock, they had to physically rotate the entire cystoscope with their wrist.
And when a human wrist rotates a rigid instrument, it's very easy to accidentally push inward or pull outward by a millimeter or two.
Right, you lose your depth control. One injection ends up slightly deeper than the other, and it ruins the symmetrical coaptation.
So how did they fix that?
Well, the manufacturer developed a proprietary tool called the Bulkamid rotable sheath.
Okay, what does that do?
It separates the viewing axis from the working axis. The sheath allows the working channel, which is the tiny tube that holds the injection needle, to rotate 360 degrees entirely independently of the main shaft of the instrument.
Oh, that's incredibly smart.
It is. So the doctor holds the camera perfectly steady, locked at the exact required depth, and simply dials the needle around the clock face to the different injection sites.
It removes the wrist error completely.
Exactly, ensuring all deposits are on the exact same level, creating regular, even bulking around the entire circumference.
I was reading through the surgical guidelines for this rotatable sheath, and there was one safety warning that really caught my eye.
Oh, which one?
They instruct doctors to literally keep an eye on the tiny blood vessels in the wall of the urethra while they're injecting the gel. Why are they monitoring blood vessels so closely if they are just injecting a water gel into the muscle layer?
It comes down to tissue health. The tissue lining the urethra requires a constant healthy blood supply to survive.
Right, of course.
If the physician injects too much gel or injects it too close to the superficial lining, the physical pressure of the expanding water gel can compress those tiny blood vessels against the surface, physically crushing them shut.
Wow, so the gel basically acts like a microscopic tourniquet from the inside.
Yes, exactly. That cuts off the local blood flow, which is a condition known as ischemia. And if the tissue is deprived of oxygenated blood for too long, it can die.
Which is necrosis.
Exactly. Therefore, the doctor is constantly watching the camera monitor, injecting the gel very slowly, and ensuring that those delicate red vascular networks remain clearly visible on the screen the whole time.
And I read they use a constant flow of water during this, right?
Yeah, to facilitate this clear view, the procedure is performed with a constant flow of water dilating the urethra, keeping the mucosal folds open and the field of vision completely clear.
Okay, so if this procedure is just a 20-minute outpatient visit with local anesthesia and no surgical incisions, and the science is this elegant, we have to ask how it actually stacks up against traditional surgery.
Because there's always a catch in medicine.
Right. When we look at the hard numbers from the clinical trials, what is the actual efficacy rate?
Well, we do have to evaluate the trade-offs here. The subjective symptom improvement rates, meaning the patient reports feeling significantly better and experiencing fewer leaks, those range from 60 to 80%.
Okay, that's pretty good.
But the objective cure rates, meaning the patient is entirely dry during rigorous clinical stress testing, those sit between 40 and 60% at the 12-month mark.
Ah, okay, so a 40 to 60% absolute cure rate.
Right. Now, the long-term durability has been demonstrated in follow-up studies extending up to 7 years, which is great.
But the literature also clearly notes that approximately 25 to 30% of cases require a top-up re-injection to achieve or maintain that efficacy, right?
Yes. Roughly 1 in 4 patients will need to return for a little more gel to perfect the coaptation.
Now, contrast that with the gold standard surgical option, which is a mid-urethral sling, like the TVT. Slings are undeniably more efficacious, with objective cure rates regularly climbing up to 90%.
Yes, a synthetic sling is highly effective at stopping the leak, but that higher efficacy comes with a vastly different risk profile.
Right.
While Bulkamid shows lower absolute cure rates than slings, it offers superior safety and tolerability. The complications associated with the hydrogel are almost entirely minor and transient.
Like what? What are the common issues?
The trials report things like acute urinary retention, which is just a temporary inability to empty the bladder right after the procedure, or minor urinary tract infections or de novo urgency. But those usually resolve quickly.
And the sources heavily emphasize that erosions, where the implanted material physically breaks through the vaginal or urethral tissue, are extremely rare with Bulkamid.
Yes, extremely rare.
Which is a huge contrast to those older particulate agents we discussed earlier. Those carbon bead or solid silicone injections carried severe, life-altering risks.
They absolutely did. The particles could migrate to lymph nodes or other parts of the body. They caused massive, painful granulomas or even led to urethral prolapse, where the weakened tissue basically collapsed outward under the weight of the scar tissue.
Which sounds horrifying.
It was. Those historical complications cast a very long shadow over the entire concept of bulking agents for decades.
But shifting to a non-particulate hydrogel changes the biological equation completely.
It really does. Because the polyacrylamide integrates into the tissue network without hardening, and because it totally circumvents the immune system's attack response, those severe permanent risks are largely removed from the clinical picture.
So what does this all mean? For you, the listener, understanding these sources really comes down to evaluating a highly deliberate personal trade-off.
Yes, it's a sliding scale of risk and reward.
Exactly. With a surgical sling, you are accepting a higher risk of permanent, potentially severe complications like mesh erosion or chronic pain in exchange for near-guaranteed absolute dryness.
Right.
But with Bulkamid, you are accepting that you might not be 100% dry on the first try, and you might need a top-up injection down the road. But in exchange, you are securing a significantly lower risk of permanent anatomical complications.
I agree completely. And the clinical guidelines highlight another critical advantage to this approach. Choosing the hydrogel does not burn any bridges.
Oh, that's a great point.
Because Bulkamid doesn't create dense scar tissue or alter the fundamental architecture of the pelvis the way a mesh sling does, a patient can still elect to have surgery later if the gel proves insufficiently effective.
So it really functions as a logical, low-risk first step on the treatment pathway.
Exactly. It's a great starting point for many patients.
You know, we started this deep dive exploring what sounded like a paradox, injecting water to fix a leak,
It does sound counterintuitive at
it
first.
really does. But unpacking the sources revealed the incredible biomechanical engineering required to make that work. Medical science is utilizing a 3D cross-linked matrix to permanently thicken a microscopic wall, meticulously restoring urethral coaptation.
It's fascinating
It
physics.
is. It physically relocates the urethra to hijack the body's own abdominal pressure, basically sealing the tube shut during a cough without creating a permanent static barricade. And for you listening, committing to understanding the nuanced mechanics of your own body and the true nature of the medical options available to you is just incredibly empowering.
It really is. Understanding the specific mechanisms behind a treatment completely changes how you navigate your own healthcare decisions.
Absolutely.
And as we conclude our analysis of these texts today, I want to leave you with one final thought to mull over a question that arises naturally from the physics of this material, even if it isn't explicitly answered in the current literature.
Okay, let's hear it.
Well, we know this polyacrylamide hydrogel is non-biodegradable. It integrates permanently into the tissue. So how does a perfectly static, unchanging 3D water gel implant interact with a human urethra over 20 or 30 years?
Oh, wow. Because the body changes.
Exactly. The surrounding human tissue will inevitably continue to age, sag, and lose its natural elasticity. So will the aging tissue simply stretch and loosen around the rigid geometry of the gel, eventually rendering it less effective?
Right, because the gel stays exactly the same.
Yes. Or could these permanent microscopic water pockets slowly alter the anatomical structure and blood flow of the aging pelvic floor in entirely new, unforeseen ways as the decades pass?
How does a permanent, perfectly static fix behave inside an ecosystem that is constantly aging and shifting? That is a brilliantly complex question for the future of urology.
It's definitely something researchers will have to watch.
For sure. But for now, the literature shows we have engineered a highly effective way to fix the leaky faucet from the inside out without having to tear out the plumbing. Thanks for joining us on this deep dive.